Good evening, Dr. Phil here. Today we will be discussing on the control of respiration, part 1. The control of breathing is coordinated by the higher centers of the brain, including speech, emotions, voluntary control of breathing, and action potentials in motor pathways, medullary chemoreceptors, which are sensitive to decreases in pH and increases in PCO2, carotid and aortic body chemoreceptors, who are sensitive to decreases in pH, increases in PCO2, and decreases in PO2, stretch receptors of the lungs, proprioceptors in muscles and joints, receptors for touch, temperature, and pain. The respiratory center controls autonomic rhythmic breathing. It is mediated by a brainstem respiratory center influenced by physical and chemical reflexes. The autonomic rhythmic breathing can be interrupted by coughing, vomiting, sneezing, hiccuping, swallowing, singing, reading, speech, and vigorous exercise. Inputs. The medulla is a respiratory center. The respiratory pattern is generated here. Voluntary and involuntary impulses are coordinated. The medulla contains receptors for excitatory neurotransmitters such as glutamate. Activity is inhibited by opioids. Inhibitory neurotransmitters such as GABA and glycine. Afferents to the medulla includes cortex, vagus nerve, hypothalamus, and pons. The pontine respiratory group is also known as the pneumotaxic center. It contributes to the fine control of respiratory rhythm by influencing the two main groups of medullary neurons, which includes the ventral respiratory group and dorsal respiratory group. The ventral respiratory group is predominantly expiratory, primarily stimulates the external intercostals, internal intercostals, and abdominal muscles. The pre-Botzinger complex is a group of neurons believed to establish the basic rhythm of respiration. The dorsal respiratory group are primarily inspiratory and is responsible for stimulating the contraction of the diaphragm. Reciprocal innervation. As activity increases in one or other of these groups of neurons, inhibitory impulses are relayed from the other, resulting in the reversal of the respiratory phase. Receptors. Central chemoreceptors, peripheral chemoreceptors, and mechanoreceptors. The central chemoreceptors are located at the anterolateral surface of the medulla. It is acutely sensitive to alterations in pH. As blood PaCO2 increases, this results in increase in PCO2 of the CSF, cerebral tissue, and jugular venous PCO2. Increases in CSF PCO2 results in decreases in CSF pH, and this stimulates the chemosensitive areas by a mechanism not fully understood. Why does respiratory acidosis stimulate greater ventilatory change than metabolic acidosis despite a same blood pH? It is because the blood-brain barrier is permeable to CO2 but not to hydrogen ions. Over a period of hours, this CSF acidosis is corrected by the bicarbonate shift. Peripheral chemoreceptors are located in the carotid bodies, found close to the bifurcation of the common carotid artery. In the aortic bodies, along the aortic arch as well. The cause of efferents. The efferents from the carotid causes along the glossopharyngeal nerve, and the efferents from the aortic bodies causes along the vagus nerve. The peripheral chemoreceptors are sensitive to decreases in PaO2, increases in PaCO2, and decreases in pH. Fever enhances the responses to hypercapnia and hypoxia. Hypoperfusion is a stimulant due to stagnant hypoxia. Response time is 1 to 3 seconds. The peripheral chemoreceptor stimulation may also mediate increases in bronchiolar tone, increases in adrenal secretion, hypertension, and bradycardia. What are the effects of anemia and carboxyhemoglobinemia? Peripheral chemoreceptors mediate less respiratory stimulation. What are the effects of carotid endarterectomy? Nerves to the carotid bodies may be lost during carotid endarterectomy. The subsequent loss of hypoxic ventilatory drive, however, is not usually significant. Mechanoreceptors. Stimulation of these leads to afferent input to the respiratory center via the vagus nerve. Their importance remains contentious as patients with denervated transplanted lung or with bilateral vagal block demonstrate normal ventilatory patterns. The inflation reflex. The stimulus is increased transmural pressure gradient with sustained inflation, and the response is inhibition of inspiration. Deflation reflex. The stimulus is decrease in lung volume, and the response is inspiration is augmented via a reflex excitatory effect. We move on to disorders of respiration. Apnea and hypoventilation are commonly caused by anesthetic drugs such as opioids, neuromuscular blockers, inhalational and IV anesthetic agents, hypocapnia or profound hypercapnia, hypothermia, hypoxic or traumatic brain injury, patients with type 2 respiratory failure who rely on hypoxemic drive for respiration and was given supplemental oxygen, and primary alveolar hypoventilation syndrome, which is a rare cause. Causes of hyperventilation includes inadequate anesthesia or analgesia in the anesthetized patient, hypercapnia such as in rebreathing, malignant hyperpyrexia, pontine hemorrhage, pain or anxiety in conscious patients, abnormal respiratory patterns. Keene-Stokes respiration is characterized by sequential increases and decreases in tidal volume interspersed with periods of apnea. It is associated with stroke, hypoxia, heart failure, and altitude sickness. Failure of the respiratory center to compensate rapidly enough to changes in PaO2 and PaCO2. Kussmaul respiration is hyperventilation characterized by increased tidal volume and reduced respiratory frequency, typically accompanying severe metabolic acidosis. Fish mouth breathing is a pattern typically occurring in patients with COPD. The patients breathe out through pursed lips to generate PEEP to keep alveoli open. Grunting occurs in neonates as well to generate PEEP to keep the alveoli open as well. Obstructive sleep apnea is a misnomer because OSA is not strictly a state of apnea. Predisposing conditions are numerous, including adenotonsillar hypertrophy in children, obesity, and increased neck circumference. The stop bank is a mnemonic and a questionnaire which predicts risk. If there are more than 3 of the following, there is high risk of OSA. S stands for snoring, T stands for tired, daytime somnolence, O stands for obstructive episodes observed, P stands for pressure, increased blood pressure, B stands for BMI of more than 35, A stands for age of more than 50, N stands for neck circumference more than 40 centimeters, and G stands for gender, male gender. Anesthetic considerations in patients with OSA includes physiological changes such as hypoxemia, polycythemia, hypercarbia, systemic and pulmonary hypertension with biventricular failure, ischemic heart disease, arrhythmias and heart block, cerebrovascular events, venous thromboembolism, cognitive impairment secondary to irreversible changes in intracerebral grey matter, disordered endocrine function resulting in impaired glucose metabolism, disruption of the normal circadian activity of the HPA axis, risk of difficult airway, sensitivity to respiratory depressants, risk of desaturation post-GA in the early period, which is the first 24 hours, and the late period, which is 2 to 5 days later. To minimize risk during anesthesia, if possible, surgery should be deferred until a combination of controlled weight loss and nocturnal airway support in the form of CPAP improves symptoms. Treat associated conditions such as respiratory diseases, heart failure, pulmonary hypertension and pneumonia. Regional anesthetic techniques or local anesthetic supplementation is preferred. The use of short-acting agents if GA is unavoidable. Try to avoid respiratory depressants. Prepare a difficult airway cut. Exhibit fully awake and propped up or lateral position if under GA. Address risk factors for hypoventilation and apnea in the recovery. Post-op care in HDU with CPAP. Treat hypoventilation or apnea. Opioid-sparing analgesia if no contraindications. These are my references. Thank you.